I'm going to kick off by asking the question who and why. And I think in order to answer these questions, we want to first just explore our understanding of obesity and the particular challenges facing people who are living with obesity. So I want to start with a question. Is there a cure for obesity? So just to check whether everybody's fully awake, show of hands for yes. Show of hands for no. Okay, that's pretty good. So the World Health Organization and numerous other international health and governmental organizations have designated that obesity is a chronic disease. And if we think of other chronic diseases that we're really familiar with, I think health professionals are actually very familiar with managing chronic disease. If we think of hypertension, asthma, diabetes is a particularly good example. If you think of the model of care, how we approach managing people with type 2 diabetes, the fact that it's lifelong care, the fact that we know that it's lifestyle interventions are important, but in parallel we may well need medications and or surgery. The fact that it's often a shared care approach between hospital or primary care, or the amount of care is dependent on the complexity and severity of the condition, and that's the case for many chronic diseases. And we don't try to cure them. We know that we can't. We just try to really help people live well with their disease. And so I suppose the problem currently with obesity, it's beginning to change, but even though it's been designated as a chronic disease, often our approach to it is still not treating it as we know chronic disease should be managed. So that's kind of our first key message. So there probably historically has been this perception that if we could just get people to lose weight, that would be the solution. But no, when we really truly look at obesity as a chronic disease, we know that it is not cured by weight loss. Now, in terms of definition, so if we're talking about a disease, how are we defining it? This is probably the most comprehensive, if long-winded and quite a mouthful definition that you can see. But it is worth going through it and trying to understand the different aspects of it. So chronic, relapsing, so you'll have times when better or worse, multifactorial, huge amount of issues that contribute to the complexity, neurobehavioral, which is the bit that probably traditionally we haven't focused on, where increased body fat promotes adipose tissue dysfunction and abnormal physical forces of fat mass, and then you have adverse metabolic, biomechanical, psychosocial health consequences. But you don't have to remember all of that. The shorter version of that is that obesity is excess or dysfunctional adiposity that impairs health. So you'll notice that there's no weight or body mass index in that definition, because it can be very variable. So you can have people who have excess weight that perhaps isn't in so-called higher BMI categories, but the adipose tissue is very dysfunctional. So they have huge complexity and many obesity-related complications. Or equally, you can have people with more weight, but who don't have health impairments. And that's really important when we think of the definition of obesity, that if somebody has excess weight, but they have absolutely no health impairments, no physical, mental, psychological or functional health impairments, then they do not have obesity. It doesn't matter what their weight or BMI is. So this is the way that we need to start thinking about obesity. And in the past, we would have just thought of, the plain old BMI categories. But of course, BMI just tells you the size a person is. It doesn't tell you anything about their health. It's true that as BMI increases, risk of health impairments increase. But you cannot know from somebody's BMI what their health is or if they have obesity. This is actually how complex obesity is. This 15 years ago, a report was published in the UK called the Foresight Report, where they drew up a systems map of all of the influences on energy balance and the determinants thereby that are contributing to obesity. You can actually go online and have a look at this. It's an interactive map, but basically you'll see that they're grouped into these different areas. So food production and consumption, you've got society influences, you've got psychology, and then the individual and environmental activity. And then biology, which is a huge part, I think, from a health professional perspective, because it's often the part that we don't really get enough education on. Certainly I didn't at my undergraduate or even postgraduate levels. So it's the part that I think we really need to understand a little bit about. And if you take a lot of those determinants from that map and list them out, you'll see a lot of those biological determinants on the left there, and then some of the environmental and psychosocial and economic on the right. And I've highlighted genetic predisposition because genetic predisposition is really the biggest factor. It's the baseline, it's the foundation, and it contributes to up to 80% of our weight or our BMI. So that is pretty similar to a trait like height. That's how genetically determined weight is. And they've proven that in lots of different studies, including really famous twin studies, which I don't have time to go into, but they are really interesting and just show us how much our appetite, our propensity to gain weight, our propensity to lose weight in response to exercise or not, all of these things are determined genetically, even how we metabolize food, how we store fat, where we store fat. Genetics is a huge part of that. The reason I think it's important for us to understand this, it's not, because sometimes people interpret if you put too much emphasis on genetics, you're saying, well, there's not a lot that you can do, and you know that might be very off-putting, particularly for people who are living with obesity. But it's not saying that there's nothing we can do. There's still plenty that we can do. But what it does do is it explains why it's so challenging, why it's so difficult to manage weight if you have the disease of obesity. And that can be very helpful for patients to understand, why it is that they know somebody who could maybe, everybody knows somebody who can eat whatever they want and not gain weight, or doesn't seem to have a healthy lifestyle and doesn't gain weight. And that's hugely frustrating for somebody who's really trying their best but is still living with obesity. So us understanding that and explaining it to patients is just a small part of helping to address the day-to-day frustrations. Of course, it's never just genetic predisposition. So with any disease, and particularly any chronic disease, you've genetic predisposition and then you've the interaction with the environment. And that's what gives you the final result. I think this is a good way of visualizing that, and it kind of helps to sort of picture that idea of the chronic disease. So if you have two of these basins, but they're different capacities, so they're hardwired to have different capacities. When we're holding them in here, they're going to weigh similar amounts. But if they're put into a different environment, for example, outside in the rain, the one with the bigger capacity is going to fill up more. And it's not that they were trying any harder, it's just purely the way they're hardwired. And it also shows us that that's why we have to tackle this on lots of different levels. So you could say that public health measures and legislation and changes to our food environment and our urban environment of allowing people to have more activity, that's the environmental approach. So that's like, putting an umbrella over to try to help people. But it can't be just that, because if we're just addressing the environment, the people who are already living with obesity, the people who already are dealing with the problem, we're not helping them, because that's not going to change what's already there. So we have to also look at treatments to address the people who are dealing with the disease. Because the big critical issue with obesity is, anybody can lose weight, even somebody living with obesity can lose weight, but weight regain, up to 90% of people will regain weight that they lose. And if you're living with obesity, that's hugely, hugely frustrating, especially when oftentimes the weight you regain ends up being higher than the weight you started at. So why is weight regain such a likely outcome? Well, it's to do with this complex internal biological homeostatic network. Now, we don't have to understand it. I barely understand it, and I'm dealing with this day in, day out. It is very complex, but we need to be aware that it exists. So we need to know that in the same way that we manage our temperature. None of us are thinking about that right now. It's all happening internally. If you donate a unit of blood, your body will get it back to the baseline pretty quickly. We can't control that. It's a very carefully regulated system. Another way of thinking about it is, we're all breathing here and we're not thinking about it. But if I asked you to slow down your respiratory rate, you can actually do it. So you can use your volitional control to slow down your breathing. But how long could you do that for? Probably a few minutes, maybe a bit longer. So we can, with effort, lose weight, but the homeostatic system that does not want you to lose the weight kicks in, and eventually the weight comes back. And how it does that is, as soon as you start losing weight, the appetite hormones increase, the satiety or hormones that make you feel full go down, and your metabolic rate goes down. So you're now much more energy efficient. So the body, genetically hardwired for a completely different time, many, many, many years ago, is hardwired to hang on to that weight because it can potentially influence our survival. So that's what needs to be overcome. Another way of thinking about it is thinking about this set point. So we all have a set point, and that set point is determined genetically. As I was saying, that's a huge influence. Epigenetically in the womb, and environmental influences at a very young age. And then also, as we get older, there are other influences on that set point on an ongoing basis. So these are the things that we need to look at if we really want to have a holistic approach. Because if we're just talking about reducing calories and we're not influencing those factors that are pushing that set point up, there's always going to be that struggle. So that comes down to things like the chemical nutrient content of the food. We say unhealthy muscle, I suppose sedentary unhappy muscle that's releasing inflammatory myokines that are influencing these networks. Sleep restriction, chronic stress and pain, circadian misalignment, so sleeping at when it's dark or not sleeping when it's dark and different shift work, etc. And then medications that are inducing weight gain. So all of these factors are pushing the set point up. So we can't ignore them. We need to address them too. And then we also need to recognize that addressing them may not be enough, or for many people they may not be able to address them. If somebody has a chronic pain issue that's difficult to manage, you may not be able to address that, but you can at least acknowledge it. And then you can also acknowledge that if the obesity is sufficiently severe and complex, we're going to need medications plus or minus surgery, in addition to all of these other factors. So it's everything together, never just one thing alone. And this weight loss curve, I think, is a really good image to keep in your head and to help patients understand as well. Because any weight loss intervention ever, whether it's a dietary intervention, medications, and surgery, weight loss will begin. And as I was saying, then the brakes go on, body's not happy with losing weight, and that's when the plateau hits. Now, the difference is that if it's a lifestyle intervention, the plateau will hit sooner. Medications usually gets you down another bit, and surgery will get you down much more. But you are still going to hit that plateau. And in the context of surgery, which is what we're talking about today, it's really important to understand that, because often people will have lost a really significant amount of weight, but they're then encountering health professionals who are telling them that they need to lose more. But maybe they've hit their plateau. They've done really, really well. And it's really unhelpful to then be hearing, yeah, but you've another 30 kilos to go, or whatever the thing is. So if we have that expectation, and then we can also help our patients understand that as well. So we prefer the concept of best weight versus what we would consider a more old-fashioned approach, ideal weight. So ideal weight presupposes that there's a particular weight that we know is exact for you compared to your height. So using body mass index, inverted commas, normal BMI of 20 to 25. If we're going back to our previous definition, if somebody has extra weight that puts them in a higher BMI category, but they're perfectly healthy, then they do not need to lose weight. They can to reduce their risk, but it's not something that we have to focus on. If we think of people, for example, going for surgery, if they have a BMI of 60, they'll be doing really, really well if they get their BMI down into the 40s, and that may be their best weight. So best weight is the weight that they can sustain while being healthy and happy, and that's going to be different for everybody. So we try to focus on other measures of success, and this includes after bariatric surgery. So I've crossed out weight loss. It's not that weight loss isn't important, and it's not that weight loss happens, of course, but we're not going to focus on that as our measure of success. We're going to look at improved quality of life, overall health improvements, improved mental health, reduced need for drugs, reduced pain, and better functioning. And these are our measures of success. And yes, weight loss probably happens in addition, but we're not focusing on that. So you're probably very familiar with this. It's quite a generic chronic disease treatment pyramid, and it sort of summarizes that idea. But importantly, even though traditionally we think of lifestyle modification first and then medications and then surgery, we also have to remember that if there's sufficient complexity and severity of the disease, so in this case obesity, just as with something like diabetes, if somebody had an HbA1c of 105, we wouldn't tell them for 6 months to try lifestyle intervention. We would also go in with medications early. So it's the same in obesity, that we're going to look at the complexity and then judge, should we start with one or maybe both, and then always together. So obesity, very, very similar to other chronic diseases, but there is one big challenge that's particular to obesity that people living with other chronic diseases do not have to address, and that's weight bias. And I mention it because it has hugely negative impact on a range of levels. So weight bias is where we have negative attitudes, beliefs, judgments about people just purely because of their weight. And it's really widespread in society. So when our beliefs become widespread in society, we call it stigma. And studies have shown, there was a survey that asked people living with obesity where were the sources of stigma in their lives, and 72% said friends and family, which again is different because people dealing with other forms of stigma will often have support from their friends and family. But in the case of obesity, it's where they receive the most. 54% in workplaces, 64% when they were in school, and that includes from teachers, not just from their peers. And then in the media, 72% of the imagery used in the media when discussing obesity is stigmatizing. So we come to healthcare professionals and we think, well, at least with healthcare professionals, we would have more knowledge, so it'd be less common. But unfortunately, we're second only to family. So 69% of stigma is received in healthcare settings. And so, physicians use these kind of words, and nurses will say they'd sometimes rather not look after people with obesity. And there's been studies in dietitians as well, do a little bit better than physicians and nurses, but not much. Implicit weight bias is where you have a bias, but you're actually not even aware that you have it. And it's at a subconscious level. So it still affects your behavior, but you're not necessarily aware that you're doing it. And actually, we're probably better trained than most to have these kind of implicit biases because it can help us in other scenarios. So pattern recognition and assessing people quickly actually does depend on some sort of implicit biases. But then in this context, it can have adverse effects. So I just want to give you a quick example. This is a referral letter from a GP referring to our clinic. So Miss X is an obese diabetic who's been in denial about her weight and diabetes for many years. Last weight was 154 kilograms in 2018. She declined to be weighed today. She's failed to lose any weight despite a long discussion and advice about dietary changes and increased exercise. So this would be, pretty common that we'd receive letters like this. Is there anything jumping out at you about the letter that implies some implicit bias? And I say implicit because the GP obviously wants to help the patient, so they are doing the appropriate action in sending the referral. Anybody want to?
The use of language.
Yeah.
And the words like denial and declined and failed.
Yeah. That you don't really see them in the context of other diseases. So they're the ones that I picked out as well. Obese diabetic, we try to use first person language as much as possible, because the person isn't defined by their disease. So somebody has diabetes or is living with diabetes, somebody has obesity, they're not obese. Just like we'd say somebody has cancer, they're not cancerous. So we try to use person first language as much as possible, and words like denial, decline to be weighed indicates there probably has been a lack of trust or some negative experience that they didn't feel comfortable. And despite a long discussion advice, I think that's one that we see a lot, where I think we think that if we spend a lot of time talking to someone about diet and exercise, that they're going to go away and lose weight. But of course, with a disease process, you could have the best discussion in the world, but it doesn't necessarily change what's going on with the disease. So that's just an example of a kind of a more neutral referral letter. Unfortunately, weight bias has very damaging effects when it becomes internalized. So people with obesity are living in the same society as everybody else, so they are receiving all of these negative stereotypes just like everybody else, and then they internalize them and have a lot of these negative opinions about themselves, and that is really, really harmful. And it's been shown to have all of these negative impacts in multiple studies. So understandably, psychological adverse effects, so low self-esteem, feelings of worthlessness, even suicidal thoughts, depression, anxiety. Also, it's been shown when people experience stigma that they have stress-induced pathophysiology, so higher blood pressure, cortisol levels, and glucose levels, inflammatory factors. Maladaptive eating patterns are much more common in people who've experienced stigma, so skipping meals or binge eating. Avoidance of physical activity is much more common, and particularly bad avoidance of healthcare, which is understandable if people have had very negative experiences in healthcare, but it means that the people who particularly might benefit from help from healthcare professionals are less inclined to attend, and that includes for screening for cancer. So this slide is really just a kind of a summary of all of the evidence that I've just talked about, and the reason it's important, not only because of those harmful effects, but also in the context of weight regain. So they did a study where they looked at people who'd had bariatric surgery and lost substantial weight, and the ones who were experiencing ongoing stigma had a much higher risk of regaining weight. So stigma contributes to weight regain and weight gain, the exact opposite effect. So sorry all the writing on this slide. I just wanted to kind of finish up by sort of summarising that this old-fashioned, outdated, unscientific narrative of obesity being a problem of willpower and just needing to eat less and exercise more has led to problems at all levels. So in the general public and society, there's just lack of understanding of obesity as a chronic disease. In terms of politicians and policymakers, very little funding historically, including for bariatric surgery. In the research and scientific community, a narrow range of safe and effective pharmaceutical options, which is beginning to change, but only really in the last few years. Healthcare professionals not treating obesity appropriately, not treating as a chronic disease, and often very low referral rates. Media and social media can be sources of misinformation, and then people living with obesity, their family, friends and support networks, the people themselves dealing with this internalized weight bias, lack of support. So all of this is leading to where we are now, which is we're in a situation where we have 2 centres in a country for bariatric surgery, when we should have much more. We have a massive long waiting list to our clinic here. We have waiting times of up to 4 and 5 years to be seen, and these are the things that need to change. So coming back to the original question, who and why? So bariatric surgery is appropriate for people with complex obesity, when we're defining obesity correctly, when the risk of not treating is higher than the risk of treating. And that actually covers a lot of different things, and we can talk about that across the day. And then also always emphasizing that they have access to multidisciplinary pre and post-op care because of all of those other factors that have to be addressed. And then why? Well, surgery, when indicated, is just a part of chronic disease care. It's not the final step, but it's part of the journey.